All right, so we're going to go ahead and get started. So work your way back in. Mindy, how's the hallway look? All right. Perfect. So we'll go ahead and get started with our next session of transforming care and talk about quality improvement approaches to address social determinants of health. And I'm excited to have Trudi Matthews and Jessica Sass come up and talk about some of the programs that they've worked on. I'll read off Trudy's bio and Jessica's first, and then we'll welcome Trudi to the stage. Are you speaking first, Trudi? Okay, I thought so. All right. So Trudi Matthews serves as the Chief of Value-Based Programs, Public Policy, and Community Initiatives in the Office of Health, Office of Executive Vice President for Health Affairs at UK Healthcare, the health system of the University of Kentucky. In this role, Trudi works with UK Healthcare's executive team and ambulatory leadership to ensure success and value-based programs for Medicare, Medicaid, and commercial insurers. Trudi also serves as government affairs and policy lead for UK Healthcare, overseeing a team responsible for reviewing and analyzing state and federal government policy initiatives. Trudi is also the executive director of the Kentucky Regional Extension Center, and so we are excited to have her here today. Jessica Sass is executive director of population health at UK Healthcare, as well as a nurse practitioner for family and community medicine. She completed her Doctor of Nursing practice degree at the University of Kentucky and a Master's of Science degree in nursing from the University of Missouri, Kansas City. Licensed as an APRN since 2004, she has worked in various care settings, which include critical access hospital in rural Northeast Kansas, providing care in the primary care clinic, emergency department, and inpatient setting, the county health department, and the women's health program and urgent care facility, and level 1 trauma emergency department. In addition, Jessica has completed a fellowship at Duke Johnson & Johnson Nurse Leadership Program focused on leadership and management skills, the Chief Quality Officer Professional Development Program through IHI, and the Agile Implementation Bootcamp through the Center for Health Innovation and Implementation Science. Please welcome both to the stage. Well, there we go. Thank you.
Well, I feel like whenever I get an introduction like that, I'm going to put my water bottle here. I always feel like, gosh, I have the best job. Because I get to wear 3 hats. They're all super fun. And I work with amazing people. So one of my we lovingly refer to a group of us who work on quality initiatives together as the quality queens at UK Healthcare. So I get to co-present with one of the quality queens from UK Healthcare today. And so that's my honor to be on stage with Jessica. I'm going to start off today by doing a little bit of background on social drivers of health and why we should care about this subject at all. It has become near and dear to me over the last few years as we've been working on trying to improve overall at a population level health outcomes for patients due to a number of different value-based programs. Let me start off by saying that, first of all, if you've never heard of this term, either social drivers of health, social determinants of health, health-related social needs, they're all basically the same terminology for this. What we know to be true about individuals is that their health, everybody's health is affected by things that we may or may not have control over. One of my other hats I wear is I'm also a professor in the College of Health Sciences, and I teach a healthcare ethics course. And one of the things that we talk about is that in creating a just society or a just healthcare system, that you want to try and maximize the advantages that the disadvantaged have in a just system. And so recognizing where there are systemic environmental issues, social barriers to care is really, really important if we care about the whole person of our patients. We want to provide whole person care. So those circumstances that people live in, family support, community surroundings, safe housing, nutritious foods, education, healthcare, pollution, employment, transportation. We all know these affect whether or not our patients are able to access the care that we provide. And then also it affects, if they come to our hospitals or our clinics and they go home, it also affects how well things go once they return to their homes. So we talk about social drivers of health, and we use the term drivers rather than determinants just because it's a slightly more user-friendly term, is that over and over the research has indicated that these things have a greater impact than actually the delivery of medical care for an individual. And identifying those non-medical factors, it's such a powerful thing together with the medical care that we provide. And so UK Healthcare is part of multiple healthcare provider networks with community organizations like you all, where we are trying to provide more comprehensive whole person care to our patients. And again, the research indicates that our health and well-being is made up of multiple factors. I think a lot of times we want to say, we think that healthcare is actually going to be one of the bigger determinants. It's really not. It's only 20% of a person's overall health and well-being. Look at the bottom there. 40% is really around our social support and material resources, our socioeconomic status, transportation, education. And then again, that's even more important than our lifestyle choices. I think if I've heard it once, I've heard it a million times, of someone saying, well, we'd like to improve overall the health outcomes, but our patients just aren't compliant, right? Well, I think that in my mind, I'm like that the conversation should not stop there. I think we all need to be a little curious. Why is a patient non-compliant? And when you dig underneath the surface, a lot of times what you'll find is that that 40% is sitting right there underneath the surface of that non-compliance. And if you're a little curious, then it won't be very long before you find those things are really underneath why patients are not compliant with the care that we want to provide them. So also when we think about a just culture, just healthcare system, we need to recognize that where you live in the world really can impact where your life expectancy. So this is just looking here across a few counties. And, of course, there's a lot about socioeconomic status. Summit County and New York County are very wealthy communities. So obviously their life expectancy is really high. But even look at Owsley County versus Jefferson County and Fayette County, a 10-year difference in life expectancy just in those geographies. And if you look at a micro level at the individual zip codes within those counties, you're also going to see, even here in Fayette County, there's a 10 to 11-year life expectancy zip code depending upon your where you live. And so these things, again, are just a part of the why this really matters or should matter to all of us. So as if that's not enough, just doing the right thing. Also, too, you can also say when you go back, Trudi said the federal government, the state government made me do it because it really is true. So I'm going to talk a little bit about the factors that are at a regulatory level that are influencing the emphasis on social drivers of health as well. So for all of us who are part of hospitals and health systems here in the room, beginning in January 1, the Centers for Medicare and Medicaid Services have required that we do what they call health-related social needs screening. Again, it's just social drivers of health by another name. And we're required to do that screening through the inpatient quality reporting system. So there are 5 domains and Jessica will talk a little bit more about that we need to track. And again, this is part of a federal, a big federal initiative to work on health equity, health disparities, and make sure that individuals who have barriers to care are able to access that care, and particularly the underserved and those in disadvantaged communities. So again, this is, the federal government is putting this in every regulation as they roll it out. So it's been in hospital inpatient reporting. Now in 2025, the outpatient prospective payment system rule, proposed rule, has stated that it's now the social drivers of health needs to be part of that as well. And then Joint Commission for those of us who have to go through accreditation as hospitals or health systems, or even at Joint Commission clinic level accreditation. There will be questions around what are you doing to reduce healthcare disparities and to work on that. And again, social drivers of health can be part of your response to those questions. The slides have a lot more bullets on them. I'm not going to go into individual detail, but that's a resource to you as well if you're wondering what those requirements are. And then for those in the room who are part of federally qualified health centers, so in UDS reporting for 2024, you have to report back the number of patients screened, the screening tool that you use, the positivity rate factor. Now, again, none of these requirements say you have to do follow-up yet. All of them are now just starting with you have to screen for social drivers of health, but it's not going to be long before we're also going to be asked to do follow-up as well. So we've been a part of these federal initiatives before. It starts with just initially doing the screening and then follow-up is added later. And again, for FQHCs, if you're not screening, then you have to have a justification for why not. I think it's going to be over time, those requirements are going to continue to get even greater. So for those of us who are part of hospital systems or health systems, there are two different Medicaid-directed payment programs in the state. One is called HRIP, the Hospital Rate Improvement Program, and then there's a university Medicaid-directed payment program that U of L, UK, and our partners, Norton, King's Daughters, and St. Clair Medical Center, or St. Clair, UK, St. Clair will be part of. And under that, those programs, we are required as well to do social drivers of health or social determinants of health screening. On the university side, we've matched our requirements with what is in the hospital inpatient recording. So we're reporting, or we're asking questions around those 5 domains. And Jessica, again, will talk a little bit more about that. And again, like on the hospital side, they're using the Accountable Health Communities health-related social needs screening tool, which is a little bit more extensive than those 5 domains. But again, those things are required as a part if you want to participate in the directed payment program and receive that supplemental funding. And you have to, there are benchmarks involved or will be over time. And so all of us are going to see this as we move forward. These are relatively new initiatives, but again, at the federal level, at the state level, these programs are put in place to encourage us to screen. For all of us, we have to ask the question, if screening is not enough, what are we going to do about it? And it won't be too long before we're asked to do even more than screening. We're asked to do follow-up and then also to report how we did in all of these areas, and it'll become a part of our performance in all of our value-based programs. So I put that all out there because, again, there's both a regulatory impetus to do this, and then also it's really the right thing to do for our patients in Kentucky. And I'll do it for the one side, but I also want to make sure that we all understand that this is really about better patient care for patients in Kentucky. So with kind of providing that as a background, I'm going to transition over to my friend Jessica, and she's going to talk about how UK Healthcare has been implementing this. And we'd love to have a conversation with you all because we know you've been doing this as well. We're not the only ones. We're going to share our experience, and then we'd love to have a conversation about that. So, Jessica.
Right. So because we were able to align our inpatient screening domains with our outpatient screening domains, we were able to create a fairly standard process for implementing screening. These are the 5 domains. And this is a very high-level overview of our implementation scope. So we had to screen all adult inpatients. We also had to screen all adult and pediatric patients in our ambulatory space. Again, the 5 domains, but for our what, yes, we had to screen, but we also wanted to make sure that we were providing follow-up for those patients that screened positive. We wanted to make sure we could provide them help. We also had to screen at least annually in the ambulatory space. We also had to screen for every admission in the inpatient space. It was a reporting measure for this year, which gave us some time to get our feet under us, get a plan, get going. But next year, it's a performance measure. We'll have a percentage that we have to meet. And then for the how, we really wanted to make this standard. We wanted to make it electronic so that it was not really creating an excess burden on our clinics, on the staff in the hospital to get this done. We wanted to make sure that we provided comprehensive training to anyone that would be involved in this process. And we needed to make sure that we were collaborative with all of our community partners, with entities within our healthcare system to make sure that we provided really comprehensive screening and follow-up. So in order to do this, we created some tools. We created an opportunity to be able to have the screening completed through the MyChart. So e-check-in, people who scheduled appointments, had the patient portal, they could do it at home before they came in. If they chose not to do that, we wanted still to have an electronic method because we know that patients are more truthful when we're not asking things to them face to face, especially with these sensitive topics. And so when they were in the room, being roomed, they had an opportunity to do this electronically on a tablet. If they chose not to do either electronic option, then the rooming staff would ask those questions. And the good thing about all of that is it fed right into our electronic medical record, which allowed us to have that information available across inpatient, outpatient, and it allowed us to have a better picture of what was going on with our patients. So these are the questions that fall within those domains. Now for the interpersonal safety, you can see for adults, they're broken out for intimate partner violence versus safety and environment. This became a heavy topic for us at UK Healthcare. At what age do you really start asking the intimate partner violence questions versus the safety and environment? And so we took a lot of time around this topic, having conversations with our pediatric providers, our providers in primary care who also saw pediatric patients. We really wanted to understand what made the most sense. And so in the end, we came down to, if you're 18 and older, the questions will be the intimate partner questions for you automatically. If you are 17 and under, you will get the safety and environment questions. We made those intimate partner questions available for anybody 13 to 17 as well, because we know some of those patients in those age ranges need those questions, but not everybody does. So we were able to come to a compromise, which has worked out pretty well. We also wanted to make sure that our referral process was electronic. We were asking our rooming staff to do some extra work, especially if patients chose not to do this electronically. We did not want to create more burden for them, more work for them. And a lot of people are nervous about how do you treat patients when they say, I have food insecurity. What do I do there in the clinic room? So we wanted to make this process automatic. We didn't want people also to remember to say, oh, I have to refer you somewhere, or I have to give you a handout, or I have to do this. And so we created this question: would you like help with any of the following needs? If they chose yes for any of those domains, then it cascaded down to ask them if this was urgent. If they said no, that went to a population health pool, which then was triaged out to community health workers. If they said this was urgent, I don't have food tonight, tomorrow, that went automatically to a community health worker. They picked that up within a few hours and were contacting that patient to see what they could do to help them. We also knew that many patients would say, no, I don't have any needs. Nope, these are not issues for me, but they are. We also knew that people would say, yes, I have some issues with these, or I've had some problems with these, but also not request help. We wanted to make sure that we could provide information to everybody in our inpatient space and our outpatient space related to these social drivers of health. So this information is printed on the after visit summary for anyone who leaves our ambulatory space, primary care, hospital space. We also knew that some patients may not have these, but know someone who has some concerns with their with these social drivers of health. So we provided this information essentially to everyone. We also wanted to make sure that we provided a very comprehensive training plan. This was a big initiative that we were undertaking. People were nervous about it. They didn't fully understand why we had to ask these very sensitive questions or what we were going to do about it. And so we created web-based trainings on the how to complete the screenings. We completed web-based trainings on culturally, linguistically appropriate ways to screen people, to interact with our patients, to mitigate questions, pushback from our patients. We talked about why we screen. We talked about next steps after screening. We wanted to make sure everyone knew what was happening if that patient had a concern. We wanted them to also know it was not their responsibility to give them the information to make sure that they address the social drivers of health, but that they could at least speak to, we have someone who will contact you. We have someone who will be helping you with that. We also wanted to make sure that everybody in the ambulatory space was trained, our inpatient case management, and then even our inpatient nursing staff. We created a video. It's a patient-facing video, but we used it in our training as well for our staff. It goes out through the MyChart as the beginning portion of the electronic screening. And then we created digital screens and stands with QR codes, which would take you to the video. We wanted to really make sure our patients also understood why we were doing this, why we were asking these sensitive questions. Also wanted to make sure everybody sort of checked their assumptions. You know, we wanted to make sure everybody knew that the message mattered, the way that we acted mattered, the way that we interacted mattered. It mattered for how patients perceived the questions, answered the questions, and we also wanted to give them phrases that they could interact with the patient that didn't convey judgment around answers, questions. Even with all of this, we certainly had some barriers and things we needed to mitigate. It happens with every initiative. One of the things that we just talked about, the intimate partner questions for adolescents. That was something that took a little bit of time for us to work through, but we came to a very good compromise on that. And I think our patients probably are getting better care since we went through those conversations. The use of tablets. Everyone wanted a tablet. Every provider wanted a tablet. Every nurse wanted a tablet. Every room wanted a tablet. Tablets for everyone. Well, we don't have that kind of money. So we had to really think about what that looked like. The other thing was, are these tablets going to walk off? Where are they going to go? How many are we going to lose in the first month, 6 months, a year of, implementing this? And then what happens to those tablets if they walk out the door? Does the information get turned off? So we had to talk through all of that. Certainly lots of conversation with finance, IT, all of the people involved to make the tablet happen. Electronic translations. I think in my mind, we could just say, we want these translated and let's get it done. Well, it doesn't quite work that way. And so when we were talking about having electronic translations, then no, that's months out. Like, that's not going to happen. And so we settled on, we'll translate our top 6 languages to paper we'll get those then into the system electronically while we work on getting these screenings electronically built into our EMR. And then our community partner awareness. We had some initial conversations with our community-based organizations. They didn't know these regulations were coming. They had no idea what was about to hit them when UK Healthcare started screening for these 5 social needs and referring to them. And so we needed to make sure that they understood this was happening, what was going to happen as far as volume, and how we could be very collaborative in this process. And then as Trudi spoke, we had to be able to report this information. We also wanted this information for ourselves. This tells us how we're doing. Where can we be better? Where do we need to focus our efforts and follow up? And so for our inpatient and outpatient, we have dashboards. So right now, about 50% on our inpatient space, we have a little bit of an IT thing we're working through. That's pretty normal, I think. And so you can see also in our inpatient space, food insecurity is our #1 health-related need. In our ambulatory space, we're right around about 67% for our screening rate. Also, food insecurity is our #1 health-related need in our ambulatory space. Out of the patients that we've screened, about 10% have screened positive and requested help, and about 4.5%, 5% of those patients have had an urgent need. So what is the role of population health in SDOH screening? Short and sweet, improve the health of outcomes, groups of people, individuals, all the people, right? But it's more than that. It's really being able to identify barriers early. It's being able to reduce the barriers, break down those barriers, and provide coordination of care. Through all of those activities, we can then start to improve the outcomes of our patients. This is our population health model. It's a very busy slide to say. We identify the type of patients that we have, the care that they need, the appropriate care model that goes into that, and how we can be financially responsible in caring for those patients so we can not continually drive up the cost of healthcare, but reduce it. This is our ambulatory workflow. So the patient schedules an appointment. If they have the MyChart 7 days before that appointment, they get the screening. Also comes with the video. They can choose to complete it through the e-check-in. If not, then when they show up to the clinic, the nursing staff would hand them a tablet. If they choose to do it on the tablet, that's great. If not, then the rooming staff was trained to complete that. Regardless of how they complete the screening, if they screen positive and request help, it comes to the population health pool for addressing that need. And then this is the community health worker workflow. High level, comes to the pool, the community health worker reaches out. Is the patient interested? If so, we enroll them in the program, and then we certainly start to figure out the specifics about that need and how we can break down that barrier and help them. We also look to see if there are other programs within population health that the patient might benefit from, and we would refer to those programs. This is a little bit more in depth of some of the things that our community health workers are doing to help patients. So certainly assessing for other social drivers of health and helping with those needs, food, housing, utilities, all the things that we've talked about, transportation, but also some of our patients didn't have car seats. You can't go to a visit if you don't have a car seat with a child. Ramps, they needed a wheelchair or walker, and they had all these steps, and so they weren't going in and out of their house. So we were able to find a place to build ramps for people to get in and out of their house. Appliances, people didn't have appliances. They didn't have bed to sleep in. They were sleeping on the floor. Well, that's not really very comfortable for more than a night or two. And so we were able to do that. We would call one patient, and she'd be said, "Hey, I'm going to court on Tuesday for eviction. Can you help me?" We were able to provide some rent assistance. We weren't. We were able to work with our partners to find rent assistance, but she didn't get evicted. And so these are just some of the ways that we've really been able to help patients once we've identified that these needs were happening. Our inpatient workflow, patients are admitted to the hospital. Case management sees those patients within 24 hours. They complete the screen, and they really try to address as much as they can before those patients are discharged. We know that there's only so much that inpatient case management can do from an inpatient space. So a lot of times those patients would then flip over to our transitions of care management program. And so as we were calling them within 48 hours of discharge, we were seeing the storyboard that told us how they screened on those social needs. And we could follow up on those. And if we needed to connect them with a community health worker, we could. If we needed to refer them to some of the other programs within population health, we could do that as well. One of the things that we noticed related to social needs and transportation is some of our patients were not coming to their well child visits because they didn't have transportation. When we started calling them ahead of time of their visit, we started to make a difference in them attending appointments, because when they have an appointment and they just don't show up, it's hard to do anything about that. But when we started calling them ahead of time and asking them about transportation, about food, those kinds of things, we were unraveling a lot of things that were keeping them from coming to the well child visits. Car seats. Number of people are like, well, I had a car seat. I don't have a car seat anymore. I can't come. And so we were able to provide car seats to some of our patients so that they then could complete those well child visits. This is a slide to really say population health cannot do this alone. These are all of the entities that we collaborate with to make all of this work happen. It takes a number of people, a number of programs, certainly dollars, to help patients with what they need. And we're very thankful for these collaborations. So some lessons learned. Finding referral sources. It's great at the second of the month. Everybody has money. Nobody's at capacity. But when you get later into the month, then some of those entities that we use significantly, they may run out of money. They may be at the max number of patients that they can help, but we still have patients that are telling us they need help. And so we have gotten really good at hearing, seeing all the things, like driving down the street. Oh, look, there's a sign. Oh, I bet they could help us. Oh, look at, there's that. Okay, we got to take that back to the team. And so that's been a little bit of a struggle for us getting started. But now that we've been in this space for a little while, we've collected a huge resource Excel binder, whatever you want to say, of all of the different places. Now we know that this church won't have anything for us today. 2 weeks from now, we can call them and get help. So that's also a little hard, is because you have to be able to manage all of that in real time and know what's going on. Otherwise, you sometimes just spin your wheels calling people. Level of engagement. So patients say they want help, but then we call them and they don't want help. So that can be a bit frustrating. But what we found out is if we continue to call them when they're screening positive, or if we follow up with them in like a month, or they've come back through the clinic, like we can start to engage with them. It's just really building that rapport, that relationship, and then we can start to help those patients. And I think too, that's also with our community-based organizations, sometimes they didn't fully understand why we were calling them so many times, or why we had so many patients coming to them. We had one community-based organization said, UK census so many people, we're only going to help one a week. Like, wait a minute, what? And we just needed to have a conversation with them and say, hey, this is what's going on. This is why there's so many people. And then we were able to create sort of that collaborative relationship through understanding of what was going on at UK Healthcare. As we implemented in our ambulatory space, we thought we had this great plan. You know, we did all this training. We thought everybody was ready. Well, the day of implementation, we realized we actually needed 2 to 3 people boots on the ground, helping in the clinics. We needed to make sure that we had an IT plan for those tablets that didn't turn on or the screenings that wouldn't pull into the tablet. And so those things became very important as we rolled this out across our enterprise. We also, again, the safety questions for children, it comes up several times because it really was something we needed to work through. And then reporting. So we had a report that told us when everybody was overdue for their health related screening. We had nothing to tell us when somebody was about to be due. And so we couldn't be proactive. And that became an important discussion with our IT team. How do we know when someone's coming due versus when they're overdue? And then in our inpatient space, really just making sure that we provided coverage across the enterprise for those adult patients. But then the weekend, we didn't think about the weekend. There's minimal coverage for case management on the weekend. And so we had to think through what that would look like. Pregnant moms in on Friday, out on Saturday, we were missing them. And so we had to really think through how we were going to make sure we captured those patients. And then some of our other social workers in more specialty areas, we needed to make sure we got there to them and did the training there and helped them understand what the importance was around all of the screening and how that process worked. And I think that's it. So we do have some time for questions.
Does anyone have any questions? Any questions? We can see, perfect, Whitney. Oh, 1 second, and I'll bring you, oh, no, I'll come back. Well, so I can hear you online too. Yeah.
Do we know when this is going to be a requirement for promoting interoperability or for MIPS?
That is a really good question because it was not in the physician fee schedule rule this year. I think there's a quality measure that you can report around SDOH that's part of MIPS, but it wasn't in this year's rule. I would imagine it's probably coming in future years. There are enough EHRs that do not have an embedded screener. I think that they've got to try and move that along. I will say I actually sit on the ONC High Tech Committee, and this is a topic of conversation a lot, is just how do we improve technology's ability to and support providers with screening and then with connecting well with community-based organizations. And so it's on the federal radar screen. Yeah.
And Whitney?
I am curious your all's work with the SNSE HEDIS measure. So for the social need screening and evaluation, we know that's a new HEDIS measure. A lot of practices payers are really focused on that. The state's focused. I know Epic has a really good ability on the back end to map those link codes. So I'm curious your all's perspective for that, and then any kind of lessons learned you can share with providers trying to figure this out.
So Whitney, we did do throughout our implementation time, talked with all of the MCOs about their, how we could share the information related to clients, how we get that information there. So we had initially started with Z codes, but we understand that that does not work for your HEDIS reporting. So we're in the process currently. It's not an easy job, at least in our electronic health record. Maybe others in the room, you have figured this out. So please wave to Brent and flag this down. It's not an easy job to create that kind of those types of custom coding that will come over on a claim. So I feel like, kind of linking to the last question, the interoperability issues of how we share this reasonably with MCOs is still, this is just still awfully new, and we're not working, I would love for us to just seamlessly be able to share that with managed care organizations, but we're not quite there yet. At least, we haven't cracked that code. Anybody else in the room done that? Oh, Rusty, of course you have, Rusty. Brent, Rusty's going to
Sure.
tell us about this because, Rusty and I have worked
Here you
together for off and on for
Many years.
20 years, many, many years, right, Rusty? Yeah.
So one of the things that we're doing is working with Payer Platform with Epic. And so there are functionalities in there that allows you to share, the provider to share that with the payer if that's available, and through I think it's called HPCS, to share that back with us once you guys, the payers have determined that. So that may be one of the platforms we use to do.
Do you know what part of the payer platform you have to have implemented for that to work?
The ECDE,
Okay. All
the
right.
first thing you have to do allows you to turn on the social determinants of health
Okay.
exchange between the provider and the payer. And then the HPCS allows the payer to push those back to us.
Great. So for those of you who are Epic EHR users, so write all those letters down and just know that that's the something you need to work on. And we'll come back to you, Rusty, and have you tell us more about that.
Well,
Other questions?
Any other questions? One more.
Hi, I'm Angela from Russell County. For the hospitals that are not university-based, the HRIP, is there going to be an increased percentage next year, or are they remaining at 75% successful completion for the SDOH?
Yeah, so you all are dealing with the fact that you have a pretty high performance rate already. I don't think that that for 26, the preprint for the HRIP hospitals has been submitted yet. So I'm not sure what I think that's probably going to be a point of discussion with Kentucky Medicaid. But, I think we fully all expect that there's going to be an expectation that we're going to have fairly high rates. You saw us, we're in a reporting period in the university plan, but we fully expect that we're going to have a fairly high performance rate to meet, and then that will be increased over time.
Thank you.
All right, and I think we have one more question
There's a gentleman right here.
right here, and then we'll come over there.
Marcus Hubbard, CHI Medical Group. Do you have any best practices for TCM tracking for a patient? Do y'all do a more automated, or is it a completely manual process?
Or how they come to our TCM program.
TCM tracking a patient from discharge all the way to tracking them, doing the entire
It's
process.
electronic. We have a report that tells us who has discharged, and then we pick them up off of that report. It's in Epic, and then we do everything. Our entire program is in Epic, so we monitor everything within Epic, and happy to meet with you and show you all that.
I saw that community health workers are a big part of this, where the rubber hits the road, linking people to services. And I was curious about kind of what the ratio of the need for their assistance is to the size of the workforce and kind of their caseloads, if you could speak to that.
Their caseloads stay about 30 per community health worker. Now that does depend on the needs of the patient. Some patients all they need is the information and what to do. That's pretty easy, but a lot of the patients need help with the application, with follow through, with next steps. And so that takes a little more time. So I would say the majority of the patients that are referred to us, we keep for 3 to 6 months in order to meet that need. Because if you're talking about sustainable transportation, that takes a little bit of time. If you're talking about housing, trying to find a place for them to live, or more affordable housing, there's applications and wait times. And so we have, I think, 8 right now. Around 30 is sort of the caseload for them, but it's very variable, again, because patients' needs change, the engagement changes along the way too. So that's where we have found sort of that sweet spot. They've been up around 40 to 50 depending on the referrals coming in, but that's a lot
And,
to
and
have on a
I will say
caseload.
too, to kind of get a sense of the volume. So between inpatient and ambulatory, we're we'll have probably over 100,000 screens that we'll do this year. So that's why we were like so worried about our community-based organizations. We're like, that's a lot of screens. And if we have even 10% of those that are positive, that's a big volume of additional referrals we'll be doing. So yeah, but that kind of gives you a sense of like how many community health workers to the size of the number of patients that we're getting that need assistance. Thank you
Perfect.
all so very much. We're going to transition.
Yeah, thank you. So, yeah, it sounds like with the implementation of screening, you could possibly use the incident planning as well, huh? Well, thank you. Give us just a couple minutes. We're going to get the stage set up for our next panel. And so it'll take just about 2 or 3 minutes and we will be ready to move on. So,